I try to show students that they can be advocates for change within a system if something doesn't seem like it feels right. And something that we are changing within our own model is kind of getting away from Bloom's taxonomy, where you're thinking of as more truly like a cognitive approach, but we're engaging more of like a Finks model, where you're getting not only the cognitive model, but you're also getting at some of those dimensions of cultural humility.
Greetings and welcome to Ortho Static, the Academy of Orthopedic Physical Therapy's podcast. I am Ben Braxley, and today I'm bringing a conversation that I had with Dr. Kathleen Geist of Emory University. Dr. Geist and I talk about interprofessional education as well as cognitive apprenticeship models as they relate to orthopedic physical therapy and just physical therapy in general. Throughout the world, things have changed a lot since I was a PT student about 20 years ago. And I talked to Kathleen about what's happening now and what may happen in the future to benefit current students as well as the patients that we serve. So it's a great conversation. I learned a lot about just how different things are now, different models, different collaborations within various PT programs. I hope you enjoy our conversation and make sure to like and subscribe Ortho Static. Hello and welcome to Ortho Static, the Academy of Orthopedic Physical Therapy's podcast. I am Ben Braxley. I'm a member of AOPT's podcast team. And while my experience is mostly in the neurologic physical therapy world with a smattering of bicycles and orthopedics, I am here to bring a new and interesting conversation to our podcast format, talking about interprofessional education, as well as the cognitive apprenticeship model that happens at Emory University with Kathleen Geist. So I'll introduce Kathleen and then we'll get into our conversation. Kathleen is an associate professor and also associate director of post-professional programs. And she is currently the interim assistant director of the Emory University School of Medicine, Division of Physical Therapy. She also happens to serve as a director of the Academy of Orthopedic Physical Therapy, and she is the immediate past president of APTA Georgia. And we actually share the distinction of bookending the current president, Kathleen being the immediate past president and myself being president-elect here in APTA Georgia. So as I already mentioned, today we'll be discussing interprofessional education. And to kind of set up and guide the beginning of that conversation, I'd just like to ask Kathleen to, greet our listeners, but also start to tell us a little bit about your experience with interprofessional education, maybe when it emerged on your radar, and how it's incorporated into typical DPT education these days. Kathleen?
Oh, thank you. Thank you, Ben, for the introduction, and thank you for asking me to join you. And I hope that some of our conversations can help spark additional conversations, across the country. And I know in, education leadership conferences and other, conferences across the country, they are having these discussions. So I hope this could be helpful in maybe transitioning or transforming some other programs, maybe development of their curriculum. But interprofessional education really started within our division probably about 7 to 8 years ago. My first interaction, we did a combined learning opportunity with the emergency medicine residents. They were going through kind of their orthopedic module, but they didn't have a lot of orthopedic time within their curriculum. It was a very short, they usually have like 2-3 weeks of orthopedic content. So they wanted us to come in to kind of show them one kind of an overarching view of what some of the imaging guidelines were for the Ottawa ankle rules, Ottawa foot and ankle rules, the knee rules, share that with them. So we did that and then showed them how to do a lot of test and measures and exam techniques when someone presents to the emergency room with an acute orthopedic trauma. And we focused on a couple of areas, mainly shoulder, knee, and foot and ankle, because that was really their need of what their residents needed in the emergency room, because that was made up a majority of the patients that presented. So we spent a morning teaching the emergency medicine residents on how to do those skills. And we also brought in our students. So our students had just finished their orthopedic semester with us. And so it was a great opportunity, one, for collaborative learning amongst the professionals and the faculty there, but also the peer learning that was a part of that with the DPT students were teaching the emergency medicine residents how to do the special tests. and the examination skills. And so they worked in small groups. We had them in our kind of our simulation center, and they worked together. And then we had a case where a simulated patient presented with an ankle injury, and we videoed the emergency medicine resident how they were interacting with a patient, the skills they were employing, the technique that they were using, the quality of the technique they were using, and what their recommendations were. And so that started about 7 years ago, and it was such a great opportunity and a great learning experience for the learners, for the faculty, and it really kind of highlighted the value and the students' perception of that learning opportunity that was so rich for them, that it really kind of escalated more opportunities across our division. And since then, we've done interprofessional collaboration opportunities with our physician assistant partners, nursing partners, still with emergency medicine. We did that for many years. So it's really kind of started a nice trend, and the students are very engaged with that type of learning.
I can imagine that being a great experience, and also just kind of the league building in terms of healthcare teams, in particular emergency medicine and physical therapists get along quite well. I can say that firsthand, being married to an emergency medicine physician who often asks about orthopedic evaluation. In particular, I think the two things are like superpowers of physical therapists that help emergency medicine physicians so much are kind of the assessment of acute low back pain, which we have quite a bit of experience with, and also vertigo. But thinking about applying it to, the foot and ankle assessments, like this is really a great collaboration with them. And it's really encouraging to hear that at least at Emory, it's also expanded into, areas of nursing, nurse practitioner, PA. That's great and wonderful. I'll disclose, many years ago, I was a DPT student at Emory. I remember joining an interprofessional club that was actually innovative technologies in medicine. I was the only PT in a group of physicians and other professionals. So I love the attention that this is getting at Emory. And that kind of leads into my next question, which is, this is what's happening at Emory. Where else is this happening? What's the perfusion of this model into other programs? What are you aware of? Are there conferences about this? Tell me a little bit more about where things are going in this space.
This seems to be a very a prominent integration across multiple healthcare systems and DPT programs. We're seeing, I know, a lot of discussion around interprofessional education, not only at Combined Sections meeting, but also the Education Leadership Conference that's held. There's lots of discussion with that, and the integration of simulation labs. I know many programs across the country have developed clinical simulation labs to help with that translation of knowledge from classroom into more not only kind of student-centered, immersive opportunities for student learning kind of in a clinical environment, a mock clinical environment that's safe. They can feel free to make more mistakes and get feedback, but also knowing that this is a big trend across the country. And it's, from our perspective and a lot of our faculty discussions, it's definitely a needed trend, to make students have more of a deeper learning opportunity, and to have them be able to connect what they're learning from a didactic model into deeper learning opportunities, and they're more engaged, and that learning is provided within that context, and that learning tends to stick. They tend to retain and hold on to that knowledge a lot better than what we used to think of more traditional, lecture based. And just historically speaking, lecturing to me doesn't feel as much like teaching, because I'm really not getting, you're invoking knowledge, but I really want to know what the learners think and what they know and how they're applying that knowledge, because I really think that that's where that learning process takes place.
Yeah, back 20 years ago, case-based learning was all the rage, and it sounds like interprofessional education, especially in places like Emory, where you do have School of Medicine, you do have a very well-established School of Nursing, and even public health. I think great opportunities to kind of cross-pollinate and grow our expertise in these areas. So, question: you mentioned 7 to 8 years ago for Emory starting this. Would you say that we were kind of middle of the road? Who did this first? maybe who's doing this best? I'll ask it that way.
I don't know exactly who's done it, in terms of when everything started.
Sure.
But I think, what we're seeing is that education and healthcare are rapidly increasing in complexity. So I think it was almost a need to start that. And I know interprofessional education has, you know, been done in nursing and medicine and dentistry and pharmacology. They are all implementing some of those things, but I don't really have a good sense of who initiated it. But know that it's been around and it's growing kind of exponentially.
I think as our silos get taller, we need more bridges between them to give that structure support. So this sounds like a great opportunity for a bridge. So let's
Yeah.
transition to our second topic, which I would love for you to tell me more about cognitive apprenticeship models. This is another kind of new term. It certainly wasn't around when I was an Emory DPT student. So tell me more.
Sure. So the cognitive apprenticeship model has been around for a while. They've been using that in medicine, emergency medicine, medical programs, pharmacology. And Emory is right now undergoing a medical education transformation project, which started in 2021. And so essentially, it's the integration of this cognitive apprenticeship model that helps learners learn and understand and retain information at a deeper level. So with the cognitive apprenticeship model, this can be done. I think in a lot of the research, what you're seeing is it's done in clinical practice, but it
Okay.
can also be done in a classroom setting, which is the tendency that I have tended to naturally kind of fall into just because of how I like to interact and engage with the students. So it really starts with modeling. And this can be done in the classroom with interprofessional. We had a great interprofessional interaction yesterday with our physician assistant colleagues. And I can speak to a little bit more about this. And this is kind of the model that we used. But this really starts out with modeling. You want an expert to be able to, and this can be done with cases through problem-based learning, but the clinical teacher kind of demonstrates a skill. And during that demonstration, they really delve into their thoughts of why they asked these specific questions in the history, what led them to ask this follow-up question in the history, why did they select these tested measures as opposed to what someone else may have thought of more of the standard tested measures. But they really are kind of looking at the expert. The students are looking at the expert um, to watch them. And then following that is really the coaching. So as the mentor or the faculty member steps back, they provide, starting with, we think about part
Mhm.
task,
Mhm.
getting to the whole task, or simple cases at first, but you have the students kind of work through that and you scaffold more layers of complexity that they have to think about, providing feedback and trying to coach them as to why they chose what they did. And then scaffolding, that's kind of that layering approach of becoming more simple to more complex. Um, and the clinical teacher can kind of offer opportunities for more independent learning activities. So it may, the mentor or the faculty member may ask the student to do, a test and measure, but then over time kind of adds, maybe have them do an entire objective exam, and then the faculty member provides more feedback and asking that student to then articulate, okay, what were you thinking and why? And then the mentor can step in and say, okay, these were where I saw there were some gaps in your knowledge, and this is where you did really well. And so it can really help kind of guide the learner as to where they need to go in terms of their roadmap. And then reflection is a big part of that too. So reflecting, the clinical teacher encourages them to kind of think back through and what they would have done differently and why. And this can all be done in the classroom, through cases, vignettes. Will bring standardized patients into the classroom. I've done that on several occasions and I've had gone through this process with them. And then the final part of that cognitive apprenticeship is really exploration. Having the clinical teacher encouraging them to kind of formulate their own objectives and kind of pursuing other learning opportunities. And so that's kind of like an ongoing, but part of that is that kind of metacognitive process where we're trying to, throughout the whole cognitive apprenticeship theory, part of that is that metacognitive process where we're trying to ask the student to reflect on why they're thinking the way they are, and then kind of encouraging that reflection, because we know that that process really helps lead novices to be more experts in their practice. And so that's kind of the part that we do in the classroom. And then we also apply that same philosophy with mentoring, in our residency programs, and try to persuade our clinical instructors to kind of follow that same model. But this model is going to be instrumented across the whole School of Medicine in terms of teaching.
That's phenomenal. It sounds to me, and maybe this is an oversimplification, but it's kind of taking the best, the most desirable clinical instructor-student relationship and bringing it earlier into the program. So they're experiencing, what that could look like and could offer them in the classroom and kind of at scale. And then hopefully kind of empowering them to have that relationship when they do go out on clinical rotations. Do you feel like that's a little bit of what's happening there, or would you describe it differently?
Absolutely. I think that's, one thing I've seen just with teaching. I've been teaching for about 17 years, and our students, our learners are very different from what their needs were even 5 years ago to today. We're having to think differently about how we are presenting knowledge and how we're asking them to integrate and apply it. But I'm finding that this integration of this interprofessional learning and implementation of the cognitive apprenticeship model provides a better context for how they're using the material. They're not just sitting and passively learning PowerPoints. They're learning the why and the what behind what they're going to be doing as a professional. And it seems to help make them more engaged because they understand why this is important. Sometimes they come in, and we've noticed sometimes they come in and it's kind of like more of an undergraduate mindset. But they're like, okay, I just need to know this information for this class, and then I can put it away. And I'm hearing across the country that, students, this is across the country, so trying to really say, okay, once you're finished with this course, this information is going to continue need to know it. So it helps them integrate it better and understand why they need to know it and the importance of why physiology is important, and anatomy and kinese, why those are also important.
Yeah, I see a little overlap too with the interprofessional education model here, because while, maybe those emergency medicine, residents had less skill in foot and ankle, they probably have a lot more skill in kind of analyzing physiology. So where's the intersection of the interprofessional education and the cognitive apprenticeship? Do you see some almost like peer cognitive apprenticeship happening in that setting, or what's ideal for this group?
Yeah, I think that's a great question. We had a really great interprofessional learning opportunity with our students yesterday afternoon and with the physician assistant program. So our students just finished a 16-week orthopedic course, and now they're starting their neurorehabilitation model. So what we did is we brought in our physician assistant colleagues and our PT colleagues. We were all there together. We brought in some of the neuro residents as well, and we were all we had a case that we were supposed to act out, and we had each faculty member were teamed up with two PT students and then two PA students. And so the goal of this was, again, that interprofessional education, and the PAs were to provide the history, and the PT students watched, but also could volunteer, additional information if they felt like it was needed. And then the PAs were going to start the objective exam. And the case was a patient who had knee OA and was going to have a total knee arthroplasty, and had some lingering history of balance issues, some recent onset of incontinence. And the PAs were to start the exam, the physical exam, and then the PTs came in and did this kind of an additive physical exam. And so throughout the case, even though our PT students and the PA students haven't really gone that far to their neuro module, they definitely saw the red flags. The case was also presenting an underlying cervical myelopathy, that, and also more like a central cord syndrome, with upper extremity weakness being more profound than lower extremity weaknesses. Upper motor neuron reflexes were positive. And so they really came away, even though they didn't have a lot of the didactic knowledge as far as differential. They were able to come across and say, okay, there's something not right.
Hmm.
And that the PAs were able to see the tests and measures that the PTs did that maybe they hadn't had exposure yet. So they didn't know what a Hoffman's was, and our PTs were doing the Hoffman's. And so it was a great opportunity to see our PTs would say, we really saw the PAs do a fantastic history. They spent a long time delving into the patient's, social history. And they did a great job with the history taking. And the PA said, the PTs really brought to the table about their environment, the house, accessibility that the PAs hadn't thought about. So it really gave each school a perception of what the other brings to the table and the value of working together, because the case really wasn't all, it wasn't absolutely black and white. They kind of walked away saying a lot of things feel a little gray about our
Hmm.
interpretation of this case and what we would do. But they felt that because they worked in that environment, it was collaborative, that each individual PT and PA student, they didn't feel like they were alone. They felt like they could have this conversation. This is what I'm seeing. This is what I'm seeing. To me, it doesn't make a lot of sense yet because they haven't had that material, but they were able to kind of problem solve and say, okay, I really think this patient needs a referral. The PAs were, I think it needs imaging. We need a cervical MRI. And, the PTs were making that referral. So it was really a great collaborative environment, and everybody walked away with a greater appreciation of what the other profession brings to the table and that possibility of what that strong collaborative opportunity looks like. And the students were so engaged.
Yeah, I had this great question queued up about kind of, doing the cognitive work and reflection, but what's the hook for the students? And you just gave us the hook, which is, feeling strong in their skills and being able to share those skills with another valued team member. What we bring as team leader, as individuals, but also as team collaborators. I mean, that would be a hook for me as a student. It's still a hook for me today. I should say I'm actually now at Emory. I'm within a new Center for Physical Therapy and Movement Science, which is moving beyond just the physical therapy piece into the movement science space, which is obviously more comprehensive and collaborative than maybe that traditional silo. So, with the center here at Emory, what we're hoping to do is just what I said, as our silos are getting taller, how do we create those bridges, both in education and in research, but also to the clinical care side from Emory University to Emory Healthcare. So love the hooks, love the interprofessional education model, the cognitive apprenticeship model, and hearing just how much things have changed in the 20 years since I was a DPT student. So that leads me, I think this will probably be our kind of wrap up, our final question. So, I was a PT student 20 years ago. Things have changed in this amount of time. You're leading the charge presently on the way things are changing today. If you pull out your crystal ball, Kathleen, you look 20 years into the future, whether it's building off of interprofessional education or cognitive apprenticeship, how do you see PT education being different 20 years down the road, whether it's in orthopedics or just across the board? What's your crystal ball tell you?
Well, my crystal ball tells me, we've got to transform education, and make it more collaborative and make it within a construct that provides more deeper, meaningful learning. I see, if I had my own, ideal situation, I would have, students in the clinic day one, within that first semester, learning those earlier, professional formation and, getting familiar with that clinical collaborative environment. Um, and I think the way people are learning is different. I think there's going to be a lot of technology that's going to be so impactful with how students are learning and acquiring knowledge, pulling out, models that are three-dimensional, that students can access. It just makes it more tactile. But again, I think there's so many opportunities for improvement and also, educational innovation. Um, you know, I think trying to show students that they can be advocates for change, within a system, if something doesn't seem like it feels right, um, and something that we are changing within our own um, model is kind of getting away from Bloom's taxonomy, where you're thinking of as more truly like a cognitive approach, but we're engaging more of like a Finks model, where you're getting not only the cognitive model, but you're also getting at some of those dimensions of cultural humility. Um, Competencies related to caring, human dimension goals of cultural awareness, collaboration, learning how to learn, and teaching students how to learn with integration of that metacognitive and self-reflection goals. I think those are all important. And I see a lot of programs now already transitioning where instead of standalone courses, you're having a true collaboration and thread. So instead of a standalone anatomy, you might have anatomy with kines and then ortho all within the same kind of semester, but they all overlap and have these threads. So it's not students are thinking, okay, I'm learning ethics and that's a standalone. We're integrating how they're thinking about ethics throughout the entire curriculum. So I see more programs changing in that way as well.
I think the evolution will be really fascinating. Our technology and our ability to capture data is getting better, and we can't even imagine what it'll be like in 20 years. But there's still that cultural humility, that interpersonal component that the data will never do for us, in my opinion. And so having the students really integrate, acquire, internalize those skills, it sounds like this model feeling, bringing what we bring to the table, feeling where we're going is just going to continue to position us well, both as a profession, but also as individuals who come to this profession to impact society and improve health. So thank you for everything that you do at Emory and beyond, Kathleen. It's been a pleasure talking with you today. I look forward to sending this out to APTA Georgia, but as we do that, also hopefully getting more engagement from the Academy of Orthopedic Physical Therapy around these topics, where orthopedic physical therapy intersects with interprofessional education. So thank you.
Oh, thank you so much, Ben, for having me on today. It was a pleasure to join you. Thank you.